in terms of oral hygiene of our patients. So we published this paper, which is the outcome, I mean, the result of the, analysis of data that we have collected on 21 patients. It's sort of the building block of my work when talking about odontostomatology. The literature now is based on case reports, self-reports, but there was nothing on the oral cavity and alterations on the brain, including therapeutical consequences, for example, endofacial orthopedics together with dentistry as a whole. Let me focus your attention on what I think families may need as take-home message and food for thought, so that you can really better promote oral health of PKS patients. Patients with caries or cavities that had active cavities, once again, proper cavities, those treated, had been treated with removing, extracting teeth. So all of this was done in general anesthesia, so the patient was brought to the operating theater to carry out treatments. We saw difficulties in maintaining or keeping the right level of oral hygiene in terms of brushing teeth, but also in terms of working with dental clinics in order to give a better contribution to their children, to these children's oral health. There was no preventive sealing of the molar pits, and this is one of the 4 killers of dentistry prevention. I mean, the positioning on the surface of the teeth, especially molar pits, with sort of blind holes, sort of an invagination of the structure, so the enamel. And this is a sort of a barrier for the biofilm or the bacterial plaque. So there is no direct contact between, the fermentable substrate, bacteria, and then the drop of pH, thus demineralizing teeth. There's also an inappropriate use of fluoride. I'll be back on this point. People usually say that fluoride helps give us protection, and my patients, these patients had no exposure to fluoride, topic in the mouth and systemic.
L'altra cosa importante che abbiamo notato è.
So this was one of the options you can see in the literature. Dental eruption delay, both for the deciduous and the permanent. So once again, permanent and non-permanent teeth. And what was lacking was different elements that we expected. For example, molar teeth were not there in many cases. So we think there may be eruption, maturation, and development delay or disorder. This means that teeth remain inside, let's say, the bony tissue instead of erupting. This is what we would like to do. Orthopantomography examination. So we talked about this with Mrs. Carletti, in order to see if some teeth are missing, agenesia. This is the technical name. So we did carry out some examinations, and then where molar teeth are, because this shouldn't be happening. We treat many other syndromes, so permanent molar teeth should be there, especially the first one and the second tooth, so that we can know, we can improve our knowledge on the absence or presence of teeth. Now, let me focus your attention on what we can do to improve oral health of PKS patients. Let me talk about dental caries. Now, over the years, we have spotted a specific trend. This is what happened in the last decades. In the 1970s and 80s, by the way, this is the DMFT index calculating the average number of children with caries or extractions of teeth. Anyway, 7 caries on average all the way down to 2 in 1996 and one tooth only in 2005. So caries are disappearing thanks to our campaigns. But if you really check what happened, actually, so if you want to make a comparison between those having caries and those not having caries, you can see that there's a big gap. There's a polarization. So in general, many teeth with caries, 5 to 8 in the mouth of these patients, and they have special needs. So these are the patients we follow up. We have high prevalence levels. This means that this pathology changed its distribution. It is now polarized, so it is accumulated, I mean, piling up in the same spot. So what should we do? Well, of course, prevention. We need to understand what the main risk factors are, and we have to make sure this doesn't happen. So we have to prevent the pathology. We try and, let's say, freeze all of these mechanisms as early as possible. You can see, I mean, we know everything about caries. We know what it takes. And so we need the hosts. This means that teeth may be, let's say, prone to be attacked by caries. Of course, you need bacteria to colonize the surface of the teeth. What they need is fermentable sugar or carbohydrates. Time is a key issue. So over the years or over the months, caries develop. There's a sort of a cavitation, it demineralizes, and then you have a biofilm piling up all the way to caries. Now, The Lancet is the, well, #1 scientific, magazine in the world. It's a very important review. You can see here systemic elements. So if you have chronic, patients, well, what they show is a very high level of DMFT, which means caries or risk of development of caries. You have local factors, saliva, which is the ordinary, if you will, environment we have in our mouth. I talked, to some parents who were discussing about saliva. Saliva is altered because of many reasons, including the fact of taking drugs. In terms of quality and quantity, the saliva of these children is different, so we don't have any buffer effect. There's no break, if you will. There are more bacteria, so there's a predisposition, so there's development of caries. There's also a high count of caries bacteria. I'll be back on this point, so I will tell you, how to offer food. We don't have to contaminate it. For example, you don't have to clean, the pacifier with your mouth, with your saliva. So much depends on the bacteria strains coming very often from parents or care givers. You also have many other pathologies, including immune system related pathologies. And this is what our American colleagues told us. You can see here they have added other elements. Mother or primary caregiver with active caries, and then special care needs, and for example, carbohydrates, or once again, sugar. So if you mix, a drink with something else, for example, water, to make it, palatable. If you do this more than 3 times a day, well, this increases risk. Now, if you've chosen to do this, okay, and of course, I was talking to you about this during lunch. Of course, just do it. Keep doing it. Please try and reduce the content of sugar. So just to reduce sugar towards 0% of adding sugar. Of course, this has to be, stepwise, step by step. Or you may add other elements, for example, other drinks or sort of teas, giving taste, but which doesn't, develop caries. For example, infusions. Now, back to drugs. Now, drugs, well, especially pediatric drugs, are sweetened. Well, they have a sweet taste. Or what they do is adding substances, for example, to just like fruit juices. It's an incredibly effective, delivery system, but then they impact on the hard tissues of our teeth. This happens because if I have sweet substance in my mouth. It is then transformed into acid because it is digested by bacteria. pH level drops, I mean, it goes down. And if it goes down too much, the tissue of the teeth, demineralizes. I mean, molecules are, broken down. And this is a progressive degeneration that may lead to caries because, teeth in those cases, can be easily attacked by bacteria. So even the use, the administration of drugs, this is what I said before, and this is, substances which are added, basically sugar, in the oral cavity. There's another key point to share with you. We talked this morning about the gastroesophageal reflux. We have the same, let's say, operating mechanism, acidity in the mouth. So if, acidity is there for days and days or months and months, teeth start demineralizing. For example, you also have teeth grinding, and this means that you have a chemical component. You also have, a mechanical, let's say, effect. So this means that, the enamel, once again, the external coating is, worn out. And then you have epilepsy drugs, maybe not the real last generation ones, but in general, there's hypertrophy of the gums, the gingival tissue. So this means there's a virtual space. I mean, there's room between the gum and the tooth. So there are bacteria, biofilm piles up there. Brushing teeth is even more difficult, so the situation is in general more difficult and complicated, because if you have biofilm on the enamel, because there's more gum exposed, it's more difficult to brush the teeth. You also have the mucosa as an issue. Now, these patients tend to breathe, they are oral, they are using the oral cavity to breathe. And this means that the environment in the mouth is not helping mucosa to be healthy. There are bacteria which are selected all the time, so you have the mucosal structure, which is no longer, tonic, in good shape. And once again, this increases the risk of developing mucosa-related pathologies. So you may have unrestored caries. You have cavities where you have, plaque. This is bad for the tooth, but also for the gum. You may have superficial or deep pockets, which are sort of carved into the gum. And, many other, let's say, pathological situations that you can see here. There's an endless list of possible complications, unfortunately. Anyway, this is the general periodontal care problems. What should we do? We have plenty of alternatives, plenty of options, so that we have to carefully select. I think that this is key. Teamwork. A multidisciplinary approach. All of the, medical staff helping the family. Well, these professionals have to work together. Teamwork is crucial. Together with Professor Cocchi, from, right away, we see children now before 6 months of age to motivate, to give information, to make sure parents, do the right thing. Because, I know you have so many things to do at the very beginning all at once. So in some cases, the oral cavity is not a priority because you think you have other priorities. You may have systemic problems, and once again, they are, teeth seem to be a little neglected. Let me go back to the basics. So back to basics. I know it's basic, but it's very important. Okay, these are the key pillars to have a healthy oral cavity. Once again, oral hygiene at home, if you will, but a professional hygiene. You can see here regular follow-up visits at the dentist. This is what the WHO keeps telling us. We have to make sure there are regular, steady follow-up visits at the dentist. They tell you what to do. And then, of course, a healthy diet and the use of fluoride. So when should we start brushing teeth? Well, right away, from the first eruption. Streptococcus mutans is one of those bacteria that attacks, well, maybe not the mucosa, but it colonizes the mouth as long as there's a hard tissue, for example, a prosthesis or a tooth. And then you have many systems, of course, starting from toothbrush, maybe goes with water just to soothe mucosa. So you have to use the right techniques and instruments. I will share with you the list of which methods in a second. Once again, rinsing, you can do this with, a cloth or a gauze. So here we go. So you may have, this sort of, fabric to be used to clean in the best way possible. So when you have motor problems, so there's no dexterity, there may be gastroesophageal reflux. I mean, those conditions that, worsen the situation. So what is necessary is a top quality hygiene in the mouth. Well, in those cases, you have to do all of these things at the same time. I will also be talking about, toothbrushes. So we put into practice many different approaches, many tools, and even different ways of, brushing teeth. It depends on the age, the situation, the position of the patient, and what he or she usually eats. Once again, chlorhexidine and fluoride. Don't forget, I mean, there are some mouth washes, substances with chlorhexidine, which is fundamental. And this is to keep bacteria at bay in the oral cavity. So chlorhexidine is easy to find in the at the chemists. So this is what you may want to use for your child instead of water. I will be talking about fluoride in a second. Chlorhexidine can be used on a long-term basis. I mean, 0.12% concentration of chlorhexidine, this can be used every day. There may be alteration of the taste, but once again, only if you have a high percentage. I mean, 0.12 is fine. You also have mouthwashes with some chlorhexidine and fluoride, 0.05, 0.05 respectively, of concentration. This is good, and you can use this chronically, I mean, on a long-term basis. So which kind of toothbrush? We recommend the electric one. 7,000 revs a minute, so it can be controlled, I mean, manipulated by the parents. And in some cases, I mean, this is what happened in some of my patients, there may be seizures, I mean, epilepsy, in very, very few cases. If you haven't tried it before, I mean, if this happens, okay, just go back to the manual toothbrush, but the electric toothbrush is always recommended. The only exception is, I mean, a total refusal or rejection from the child. But, I mean, the manual toothbrush, if used in the right way, with the right motion, does work. You can see here the general positions that we recommend because, well, it makes your life easier and patient management is much easier. You can see here the right position, so you can see the caregiver. You retain the, mandibular area. You can use your finger or maybe some rubber, maybe a rubber pipe. So once again, you can brush from the back, both, I mean, in a seated or standing position. In terms of ergonomics, this seems to be the best solution in terms of the list of recommendations we have shared with our patients, so you can try both of these positions. Back to nutrition. Well, of course, here we have this fantastic Mediterranean diet, so we have to avoid high sugar foods. Once again, please avoid as much sugar as possible. Well, in some cases this may happen, I know, but then of course you brush teeth after using sugar or eating sugar. In terms of fluoride, this is a very important area, well, especially when you have a risk of developing caries, we need to use the fluoride. It gives mineral back, so it remineralizes. It fights against bacteria. It produces a sort of a new enamel, I mean, a new coating. You have a fluorapatite instead of hydroxyapatite. So there is, there's acid attacking the tooth, and this is a protection element. You have gel or gel-like substances. I will tell you, I mean, how much, and it depends on the age. At the dentist, we use a fluoride-based coating. This is something that you coat, I mean, you brush it, I mean, onto the tooth. Now, in those patients, for example, those drinking, drinks with sugar, this is a good solution. So if this is the only solution, I mean, the only way you have to make sure they take drug is, mixing them with some sweet drinks. Well, this is something that you can do. You also have gel or gel-like products, especially in those cases of major demineralization or dental, let's say, structures which are weaker. You may see some, white or yellow spots. This is a sign of demineralization. I mean, the enamel, the coating is disappearing. So we use fluoride in that case because it's one of our best friends in this case. So if there are no contraindications, it's usually kidney pathologies or renal pathologies. Anyway, these are the dosage levels. If you have toothpaste, 1,000 ppm of fluoride from 0 to 3 years, you can see here just like, a very, very small quantity. The two examples are, rice and a pea. There's also a systemic fluoride prophylaxis because this substance is very often swallowed, so it will be acting on the ossification centers, bone-producing, bone-making. 5, 6 years of age, concentration level increases. So in this case, we move to a pea-like quantity. The question is, some people here in Italy live in close to volcanoes, so tap water is already rich in fluoride. Well, there are many different solutions to give additional fluoride. So what are then the quantities recommended and approved by major associations? Now, if you use fluoride-rich water, so these are the concentration levels, I mean, less than 0.3, 0.3 to 0.6, or more than 0.6. From 0 to 6 months, for example, you don't have to use this fluoride-enriched toothpaste. So this is what it takes, and this is the right quantity. I mean, we have enough fluoride in the water or in milk, so please do comply with these values, with this table. If you don't have fluoride in your tap water, then you can use, this, toothpaste. It has to be used steadily. If you use it for less than 6 months, there won't be any effect, together with substances that are re-enriched. I mean, they sort of recharge themselves with fluoride. If the toothpaste doesn't work, you may have drops. We do have some replacement liquids. You can get, drops, oral drops. We recommend the use of drops, directly in the oral cavity. No, do not add any other liquid. They just have a direct impact on the teeth. Don't do this after taking milk or dairy products. In this case, there would be a sort of a deactivation of the fluoride. It will be, wasted. So once again, just don't do this close to meals or toothbrushing. Just a couple of minutes, if possible. I had skipped the oral facial features, the occlusion of these patients, because this deserves, a specific, highlight. I'm going back to the paper we have published, and you can see here the key features we saw. For example, a class 3 malocclusion. This is it's basically a mandibular area which is bigger than the maxillary area. We need, of course, X-ray to say if this is, a skeleton problem or not. So we have no major doubts. It does depend on the skeleton. So the jaw, the mandibular area, is a little bigger, while the maxilla, is a little smaller. As for the size of the face, I mean, the length is bigger, longer, because the mandibular area is sort of longer. We have a high arched palate because, once again, the maxilla is very small, so the vault is very high. And this means we have small nasal cavities because, this is the anatomical district where there's plenty of, I mean, we are very close, there's proximity. We also have cross bites. Now, this means that we don't have the right occlusion, both on the sides. In this case, we have a bilateral cross bite. So upper, teeth are, let's say, narrower. It's just like a lid, which is smaller than the box. So, there's a small size on the side, but also anteriorly. And this is the anterior or bilateral posterior cross bites. We have different extrinsic and intrinsic factors. I mean, they depend on the genetic situation. And you also have muscular hypertonia. So you have hypertonic muscles. I mean, the tongue is out. The macroglossia is the technical name. This means that there's no proximity between the tongue and the palate. So let's say that there's no effect on the palate. I mean, they don't develop a flat, large area. So once again, we have a small palate. And then oral breathing, and this is one of the, mal habits. I mean, small nose, respiration is easier through the mouth. The maxillary bone doesn't develop. So plenty of, I mean, it's a long chain, if you will, many, many rings of the same chain. Anyway, this is one of the reasons why we developed this kind of malocclusion. You can see here some of the data from our trial. So oral breathing, 60%. In my opinion, this is underestimated. It's much more than this. So palate is high. Open mouth posture, 100% of cases, 63% crossbite. And open bite anteriorly, 63%, prognatism. So the mandibular area is bigger in 75% of the cases we took into account. So this is the typical situation. So open bite, anterior open bite, and then the tongue protrudes. Also in terms of swallowing, because there's basically nothing on the top, the tongue has to, let's say, bridge the gap, so to say. And this means that food gets out of the mouth. I mean, there's no closure, there's no sealing, if you will. So the whole function has to be rearranged around an altered anatomy, which is what these children have. And this is what we generally do with, this is a Down syndrome patient. So in this case, there's a big difference between the mandibular and the maxillary area. We do some orthopedics. I mean, we work on the top part. We sort of free up the nose, and then we have a posterior-anterior traction in order to push it forward. I know it's a major challenge. It's a difficult thing to do, I know. And we need to be brave enough to tell the truth. Basically, there's no first and second molar teeth. And because we need to fix it, I mean, to anchor the system somewhere, we have some motor issues and delays in terms of motor development. So this means we don't have any, well, let's say, cooperation from the child. Then you have some bad habits. For example, hypotonia will be there. I mean, scientific evidence tell us that once you recover the anatomy, we also have to recover the function, so that both the anatomy and the function can keep working together hand in hand. So, of course, the maxillary arch won't retract or go back, but I mean the bite and bite problems may come back because, you know, you need to have the right function. If the function is not there, the recovery will be lost. So you will never fly unless you dare try. And we do dare. I mean, this is what we do often. There's another trial we've worked on, and this is going to be my take-home message. I know all of this is difficult. There are difficult situations, but for example, we carried out a retrospective trial. I mean, all the cases that went through our center. I mean, 80% of our patients that had the chromosome-related systemic genetic problems. So we have another, we also have a control group, I mean, a negative anamnesis group of patients. So we have measured, I mean, how long it has taken to, let's say, recover the dentistry problem. Anyway, to boil this down, we saw that we had the same time windows in terms of treatment. So usually patients coming to us with no special problems, usually the treatment was 2 years. We have to say that maybe with these children it takes a little longer. I mean, every session is longer. Instead of 15 minutes, we can spend 30 or 40 minutes with them. But believe me when I say that eventually the result was better for ordinary normal patients. We have, created specific indicators, but in terms of quality gap, this was the same. For example, we can improve by, for example, 5, 6, 7, 8%. We had exactly the same improvement for both groups. Now, of course, the starting situation, I mean, the starting point was different. So, in general, for these children, the result is a little, let's say, inferior. I mean, less good. But once again, we have to be very, let's say, we do have hope. We can do exactly the same thing for PKS children.
Thank you so much to Dr. D'Alessandro. I would like now to invite Mrs. Mancini. She works at the S.Orsola Malpighi Hospital in Bologna. And she has kind of a difficult topic because we wanted to understand the hormones development in PKS children and patients. But of course, she also deals with patients with disabilities, but in particular for PKS patients, there are no information about hormones development. So, well, she will actually explain to you what she found. Good morning to all of you. Thank you for inviting me. I would like to thank your association and Professor Cocchi. So, as Professor said, well, we do not have data when it comes to the genitals in PKS. So this is our starting point, and we hope that we will improve our knowledge. What we do about PKS patients' genitals, and in particular in girls, well, in literature, we do not find much information. I would like to present to you 3 reviews in which the genitourinary system was considered. This is dates from 2014, and in this paper, actually, they mainly talk about males, so hydrosis, small genitalia, or hypospadia. So these are the features mostly found in PKS patients. Then another review, and if we look at the genitourinary system, also in this study, some features concerned males. So the undescended testes, hypospadia, and or hip dislocation. However, these abnormalities are related to boys, and we do not have information about girls. The last one, if you look at the arrow at the bottom, also in this case, we have hypospadia, small genital, and hydrosis. So once again, no information about girls. So far, in literature, we have found information about boys. So when it comes to girls, we try to start from our experience and investigate further this topic. So now a few questions for you. If you have girls with PKS, and so these are the questions for you. When it comes to pubertal development, the first question is, when is the time of pubertal development? Is it, say, at the normal time or delayed? Of course, this means breast development, pubic hair. So these are the secondary sexual features. Then if pubertal development happens, then what about menarche? Third question, if menstruations are present, what are the features? Then, of course, well, I would like to talk with you about that. So you have girls, can you tell me something about pubertal development, girls who are 14 or 15 years of age? There is one girl who is 21 years old. My daughter is 21 years old. She developed late, so late or delayed pubertal development, menarche when she was 16, 17 years old, and she has irregular periods and abundant bleedings. So I do not have data, as I said, but I wanted to understand how periods can be managed in girls with disabilities, because in our office, we actually see a lot of teenagers, let's say normally developing teenagers, but also girls with other disabilities. As I said, no cases of PKS. However, sometimes it was actually a family's request to help them managing periods, because when a patient has disability, so menstruation can be difficult to be managed, and also from a very simple and logistic point of view. So this is a kind of a request we received by families. So I would like to share with you this sort of a scheme. So first of all, did pubertal development occur? Yes, no. Of course, if not, we have to further study the central activation of the pubertal development. If, on the contrary, we do have pubertal development, then we will ask whether the menarche is present or not, because the absence of menstruation can be caused by many different reasons. And actually, if there is no menarche, then we have to investigate actually two main aspects. and this is something we do at our offices. So first of all, hormones exams to understand ovaries and the activation of the central axis for the ovaries activation, and of course the pelvic ultrasound, because sometimes ovaries do not work, and so it's like they are in menopause. On the contrary, if the menarche is present, then the question is how can we better manage the menstruation? Now, I can tell you our suggestions, and actually, first of all, what are the problems of teenagers in general? Well, first of all, teenagers are characterized by the immaturity of the peripheral system, which means that menstruations are irregular. And actually, about 75% of periods, so actually in the first and second years, and the cycles are between 21 and 45 days, whereas in 95% of cases, within 5 years after the first menarche, then the cycles become regular. Of course, menstrual cycles vary. Usually we consider 28 or 30 days, but, well, of course, it depends on every single person. We know, however, that menstrual cycles, if they are shorter than 19 days or longer than 90 days, of course, these cycles means the time in between two periods. Well, this 19 days or 90 days, this is not a normal, let's say, menstrual cycle, so further investigations are requested. Now, this table shows all the possible causes of abundant bleedings and also long bleeding. So we said, for example, 19 days when it comes to menstrual cycle, but also abundant bleedings. Of course, it is kind of difficult to assess if the period is abundant or not, because it's very subjective, but however, a woman can tell whether it is abundant or not. And you can see here the different causes, so related to the endocrine system or other disorders, of course, pregnancies or infections, the intake of medication, and also other problems, for example, foreign bodies or traumas. Now, this slide shows the normal bleedings and the features, but I won't, go through these technical features. I'd rather like to focus on disability and menstrual cycle control. To do so, we have to consider three main aspects. First of all, the compliance, so the possibility of administering treatment or something that can be easily managed by the patient with disability. Secondly, very often a disabled girl cannot move, and so there is a risk of deep venous thrombosis. Third, we also have to consider the interactions of different drugs. For example, in the PKS, there are cases of epilepsy, and so sometimes anti-epileptic drugs may interfere with hormonal drugs. So what are the available treatments? Well, first of all, we have both oral treatments, which are the combined oral contraceptives. So this is the pill, contraceptive pill. The possibility to do transdermal treatments and the possibility of implanting subcutaneous devices. Now let's consider the pros and cons of every single treatment. Of course, the ultimate goal is not really contraception, but rather controlling the menstrual cycle and making it easier to control it. So first of all, the progestogen pill has features that create limits. Of course, this depends on every single person, because every person with PKS is different. But however, when it comes to the pill, you have to consider that you have to consider a daily administration. And actually, the pill, if compared to the other treatments, such as transdermal or the implant, actually the pill, if compared to the other, increases the risk of deep venous thrombosis. So this is an additional risk factor. And also the drug interactions, for example, with anti-epileptic drugs. And since it is an oral treatment, well, it could be difficult in case of vomit or dysphagia or diarrhea, because in this case, the administration is altered, and so the action and the effect may be altered. On the other side, we know that pills can control the cycle in the best way, so this ensures the best control of the cycle. We have some patients who actually take the pill continuously. So there are lots of ladies, lots of women who actually take the pills, where usually, you take the pill 21 days, then you stop for 7 days, which is when menstruation occurs. But actually, you can also take the pill continuously, which means for 21 days, then do not stop for 7 days, but you start immediately the next box of pills. This does not increase any risk. What happens, though, is that with the continuous intake of pills, well, menstruation does not occur. But this becomes a sort of amenorrhea, of course, and patients or women are scared and worried when we suggest a continuous intake of pills. Well, then women are scared because they won't have menstruation, because, well, the period is considered as a physiology, so women feel, they are kind of normal. But however, the menstruation induced by the pill is actually a fake one, because ovaries, when you take the pills, don't work. So actually, the menstruation is just caused by the hormones drop due to the fact that the pill is not taken during 7 days, for example. So from our point of view, avoiding the menstrual cycle could be helpful when it comes to patients with disabilities, but this does not cause any additional problem. Maybe every 6 months or every 1 year, you could just stop taking the pill for 7 days and then you resume taking it. Another possibility is the patch, which is, let's say, an easy-to-manage method in PKS patients. What are the limits? Well, it could come off, or it could cause rashes or itching. But, well, of course, in this case, what happens if it comes off? Well, you simply have the menstruation, so no problem. What are the advantages? Well, it lasts 1 week, so you replace it every week. Well, also in this case, actually, instead of stopping, you can have a continuous replacing of the patches week after week. There is no interference with gastrointestinal problems. There is no problem of dysphagia or diarrhea or vomit. And, well, another advantage is that the patch has a lower risk of deep venous thrombosis. So if the patient cannot move, we can say that this is an advantage when it comes to controlling menstruation. Last solution or option is the subcutaneous implant. which is a sort of a small rod, which is implanted in the arm, and it releases progesterone, so it does not contain estrogen, which increases the deep venous thrombosis risk, so it only releases progesterone. However, the limit is that the menstruations are not controlled as effectively as it is the case with pills. Because actually, it could happen that irregular, let's say, bleedings occur after 3 or 4 months after implanting the device. Well, usually the irregular bleedings stop, but in some cases, actually, irregular bleedings occur even after 4 months. What are the advantages? It lasts for 3 years, so you don't have to remember to replace it. There is no interference with gastrointestinal problems. There is a lower risk of deep venous thrombosis, as we said, because it only releases progesterone. So these are the 3 options we have. There is also a possibility of interaction of contraceptives with anti-epileptic drugs. These are the guidelines. So the one in these slides are the guidelines about possible interaction with other drugs. So in case of interaction, the extra progesterone effect is reduced. In this case, you see an indication of the COC, so the combined oral contraceptive, which are contraindicated if anti-epileptic drugs are used. And the same applies for the patch. However, in this case, I mean, the contraceptives are used for contraception purposes. So basically, in this case, these contraceptives are not recommended because they are less effective when it comes to menstruation control, which means that you may have irregular bleedings. And whereas for the subcutaneous implant, in this case, there is no interaction which is reported, so the anti-epileptic drug does not interfere with the action of the subcutaneous implant. Okay, this is all I had that I wanted to share with you, to present you. I thank you for your attention, and this is actually our office. I do work with Professor Mary Giola, and in particular, we actually work with disabled patients when it comes to gynecology and pediatrics. Thank you.
Adesso invito
let me now invite Mrs. Giulia Fische. I think you're right. Sorry. Maria Chiara Di Fabio from Verona. Sorry. Just moving forward a little bit too quickly. Mrs. Di Fabio will be talking about the new physiotherapeutical approaches whose names are Therasuit and Medek.
Bene, buon pomeriggio a tutti.
Good afternoon, ladies and gentlemen. First of all, let me thank the scientific secretariat for this invitation. Today, I will be presenting you 2 brand new physiotherapeutical approaches, which are not very well known, at least here in Italy. 2 different names, Therasuit and Cuevas Medek. In my clinical practice, I had the opportunity to become familiar with these 2 methodologies. This means I had the opportunity to, put them into practice from the clinical and then scientific point of view. As for the general indications of these 2 methods, well, they are the following. They say that this can be applied to pathologies with a delay of the psychomotor development. This may be generated or triggered by different pathologies, either congenital or acquired. For example, child cerebral palsy, neuromuscular diseases, spina bifida, stroke, skull traumatism, so this is acquired, together with bone marrow lesions, Down syndromes, and the Pallister-Killian syndrome. Let me talk about the features and clinical manifestations of this PKS, for which we can use the Therasuit and Medek. We may have hypertonia. As we said this morning, we may have muscular contractures and other secondary problems, and neonatal hypotonia. This may help us realign the posture. It can also help re-establish the medial line. We can also prevent or, reduce scoliosis. It's a proprioceptive spur, and it enhances motor functions. Let me talk about the first method, TS, or Therasuit. Okay, a couple of words on the background of the system. Now, this is a method that was first created in Russia. A similar approach was used on astronauts when coming back from space missions in order to fight against the negative effects triggered by the lack of force of gravity or gravitation. Effects like muscular atrophy, weakness, osteoporosis, and proprioceptive deficits. Now, over the years, the method, was, more and more often studied from the rehab and educational point of view, thanks to the incredible contribution from Isabel and Richard Kosielny. As the name suggests, they are from Poland, and they are parents of a girl with cerebral palsy. They have created Therasuit as a rehab re-educational system. In 2002, Therasuit was designed but also registered in the at the FDA in the United States. Let me give you some specific information. It's basically a personalized, a customized intensive training program for children and adults with psychomotor development delay. It is based on the use of two different tools. Therasuit, it's sort of a uniform, as you can see here, sort of a suit with elastic or stretch bands with very specific functions that I will show you in a second. We also have the UEU, which is a universal exercise unit. It's basically a sort of a cage, inside which we use two systems. Pulley system. It's basically a pulley-based approach in order to strengthen muscles. And the spider. The spider is an elastic suspension system. I will give you key details on these two tools. Now, Therasuit is to be used in order the muscular tonus, to increase the motor activity, to enhance strength and resistance. It improves functional skills, and it stimulates proprioception. So it's basically a physical therapy. So let me start with Therasuit, because it's a suit once again. It is basically a proprioceptive dynamic orthosis. What do we mean by orthosis? Now, orthosis, as you know, is an aid which is applied, onto the body of the patient, so it does not replace a joint, so it is not, a prosthesis, so it is an aid or a help for a specific function. It is dynamic because the material it is made with is soft. It is not static. It is not a rigid corset. It favors motions. It is proprioceptive. I will be using this word in my presentation. Let me tell you what proprioception is. It's basically the possibility we have of perceiving the positions of our joints in space, together with the situation in which muscles are. For example, contraction without using the site. I mean, without looking at my arm, I understand whether it is touching the table or if it is close to my body. So proprioception means giving stimuli. This suit limits pathological reflexes, it helps making gestures and motions, it helps align body segments. For example, if there's a scoliosis with, for example, a cavity on the right, what we can do is, apply some, stretches on the left. We tighten them so as to stimulate the realignment, the rebalancing of the body. We can give support to weak structures, for example, the trunk and the head, and then eventually it sort of generates gravitational force. This means we activate the core, which is the abdominal area. We know it is crucial in order to make every kind of gesture together with a postural muscle activation. Let me share with you what this suit is and how it works. Now, on the left, we can see a girl with the typical pathological situation. If you wear the suit, you can see that we can really spur or favor, the realignment, of the posture. This means that we can really perceive or give the right position of joints in the space. Let me now talk about the pulley system. Now, this is basically a suspension or pulley-based system. So we have pulleys and weights. Now, this allows patients to carry out the special movement or some motions in a selective way. You can see here the functions. We strengthen the muscles, we improve the ROM, so the range of motion of our joints. We encourage selective movements. We prevent, muscle contractures. This is typical of this syndrome. We rebalance and normalize the muscle tonus. Basically, it helps the proprioception. I will share with you some pictures, some examples. For example, here we can see a girl. She's sitting on a chair. And this is what the physical therapist is doing, so an abduction movement. So the arm of the girl is stabilized. There's a stabilizing system. It is basically suspended. There's a weight, and we also have this pulley-based system. So we ask the girl to move her arm and, bring it towards the body. It can also be used in functional positions. For example, in the crawling position to stimulate hip flexion. And within a general framework, this can also help crawling. Eventually, this is another example. You can see that the patient is now on the supine position, so lying on the bed. We ask her to do, an extension. 3 extensions. Some parts of the body have been stabilized with bands and or weights because we don't want her to counterbalance or to compensate. So in this case, we are very selective on the left lower limb. This is the second system, spider. This is an elastic-based or stretch band-based system. This means the patient can carry out the movement required with a reduction of gravitation. The key target of this tool is to, again, strengthen muscles of the patient. We will also enhance the joint range of motion. We will deliver stabilization to muscles. So we will work on the muscles. We also encourage balance, coordination, the perception of the median line. And last but not least, we will encourage functional motion. I have some pictures to show you. So we have the same girl. You can see here her position on the pelvis. She has a sort of a support. There are also stretch bands on that hook. It's sort of inside this little cage. So the physical therapist can choose the strength and even the height, if you will, of the stretch bands. So in this case, she can control the weight onto the joints of the girl. Once she finds the right position, we can perform some exercise, in this case, there's a special exercise, to stimulate the muscle of the trunk together with upper and lower limbs. It can be used also in standing position, as you can see here. Again, we can apply different elastic bands, on the, higher or lower. It depends on the pressure you want to make sure she feels on her lower limbs. And in this case, we work on this, tilting tables to stimulate proprioception. You can see here the pelvic band or belt. We ensure the comfort of the patient with some padding. Now, Therasuit includes an intensive treatment. As you can see in the slide, that you have to have a physical therapy 3-4 hours a day, 5 days a week for 3 or 4 weeks. Into this posology, this posology is based on a rationale that you can see in some of the trials carried out. During the first week, we make sure the child, gets familiar with the method. Children or even adults. So they become familiar, with the tools to be used. Then we have a functional assessment, and we define the key objectives of the treatment. So we start working with a general global muscle reinforcement system or strengthening system. The second week, we work in a very specific way. We strengthen some selected muscles. So we will work on the most important muscles in terms of reaching objectives. Third and, if necessary, fourth week, this is when we translate this effort into a functional one. We work on gestures. So let's say we improve what we have done in the first and second week. Based on my personal clinical experience, I saw that this method may be used seamlessly, let's say in an extensive way. As you can see here on the bottom of the page, this means physical therapy 2 to 3 times a week, 1 hour a day, all the time. So we improve, but at the same time we maintain what we have improved. The posology has to be carefully selected. You have to consider the age of the patient and the clinical conditions of the patient. And of course, you have to have, a medical team. Now, Therasuit is not just a method. It's much more than this. It's one of the tools of our toolkit. We can have all of these tools. This means that the physical therapist, can, use his or her hands to help the patient, which is, stabilized by these tools. So this is definitely an aid or a support for us. The Therasuit method, thanks to, based on the physical features of this pathology, it can be used for PKS. Unfortunately, this is the, let's say, the list of disadvantages or drawbacks. We don't have many trials on the use of Therasuit. Anyway, we found out that we have an improvement of the control of the trunk and of the head, and the general strengthening of the muscles. So, I'm in touch with Isabella. She has invented the method. She's talked to me about one PKS child that has used Therasuit. She couldn't use the suit because there was an umbilical hernia, but she has used all of the other tools for this child. She managed to get good improvement in terms of muscle strength. Now, these are qualitative data. I don't have quantitative data because no case report is available or a specific trial on this very case. So in my opinion, the treatment and the posology, just like other physical therapy treatment, they have to be customized based on patient's needs. You also have to consider the clinical situation of the patient. So what is necessary, once again, is carrying out, conducting other scientific trials. Now, many trials are working on Therasuit. Some meta-analysis reports have been recently published. Anyway, we are told that these trials are low-quality trials, and PK is not investigated. Basically, they work on child cerebral palsy cases. So hopefully there will be a top-quality trial with top quality scientific basis. Let me now talk about the second tool, Cuevas Medek exercises, CME. Now, CME is a psychomotor therapy invented by Cuevas Medek back in 1972. He's a physical therapist from Chile. It is based on manual exercises from, the physical therapist onto the pediatric patient. I will show you the exercises that, this cannot be applied to an adult population, and the patient has to have psychomotor development delay. The main aim of Cuevas Medek is encouraging, eliciting absent solutions, triggering automatic responsives. In terms of the posture, we will apply external stimuli from the therapist. This means that the patient will be exposed to gravitation. These 2 points are key to really understand what lies behind this therapy. So let me give you some extra info with a couple of examples. This is a very useful exercise to improve the activation of the extensor muscles of the head. As a consequence, in a functional context, you will improve the control of the head overall. Now, the head of the patient is, let's say, subject to flexion or gravitation, and the therapist will apply all of these manual stimuli on the forehead of the child. So there's a stabilization of the trunk with one hand, while the other hand is, touching, supporting the forehead of the patient. He or she will generate vibrations. There will be a 45-degree extension of the patient's head. You don't have to help the patient, no verbal stimuli. So this is a fully manual technique, and the child will understand he or she has to activate the trunk extensors. A similar exercise is the one you see in this slide. This is to spur the activation of the trunk extensors, and as a consequence, you will have an improvement of the trunk control. So you have 4 steps. You have the body of the patient exposed, to gravitation, and the manual stimulation, which is applied by the therapist. And then, last but not least, you can see here a couple of examples on standing position. This is not possible for adults, as you can see here. So in this very case, you see the child standing on the thighs of the therapist. The child is supported, and the stimulus now is received by the pelvis. So the patient, learns to have a standing position, so from proximal to distal. And we'll also have some, you can see here what happens on the lower limbs in order to, encourage other functions. So let me tell you how this is, both in practice. You have 41 items, so you have to go through, basically 41 questions at the very beginning, and this is to set the objectives you want to hit. Then you're ready to start the treatment. Now, the treatment is an 8-week-long one, and you have 1 daily session. The duration is from 30 to 45 minutes. Now, for very young children, you may also recommend 20 minutes. Parents take part actively into the treatment, and if you don't reach objectives after 8 weeks, we simply invite parents to try other alternatives, so you don't have to insist too much after 8 weeks. Now, because of the main features of the PKS, this method, CME, can be applied to this kind of pathology. So what is very important, as usual, especially here, we need to monitor the reaction of the patient or the child during treatment, because what is imposed is basically our force, our manual force, which is not an internal force, it's external. And in some cases, children don't accept it. We have to make sure they accept it, so they have to have a positive perception on this treatment in order to avoid a total rejection from the child. Once again, we don't have much data on the current scientific literature. As for Medek, we do have some books that have been published, but basically there are no scientific papers published in the current literature. So once again, it would be very useful to put together other tools to measure the effectiveness of Medek. Now, as far as my clinical experience is concerned, I have used this system on one girl, and she was not PKS. She was, hypertonic, still undiagnosed. We had good results in terms of the control of the trunk and of the head on a short-term basis, but long-term, she couldn't be assessed because of other complications, basically respiratory problems, so we couldn't, repeat the assessment. But once again, we saw a clear, good improvement short-term. So, because, talking about PKS, a new trial should be performed concerning this population. We need a multicentric study because we don't have many places, many centers around the world offering Medek. What is also useful is making comparisons. We have to compare Therasuit and Medek on the one side and compare this with traditional physical therapy to understand, if they are more effective than current, traditional physical therapy. This is it. Once again, do not be shy. So I have plenty of information on the scientific literature. Thank you so much for your attention.
Grazie alla dottoressa Di Fabio.
Thank you to Mrs. Di Fabio, and I would like to invite Giulia Fesce. She's a mom, so she will tell us her story, and she will talk about her project. The name is Orizzonte Autonomia Onlus.
Buonasera a tutti.
Good afternoon to all of you. I would like to thank Samantha for inviting me. It is really kind of touching for me to be here because we have physicians and doctors, and I'm just a mom. So my speech, well, it's the story of a mom, so I do not have any scientific evidence. However, I can tell you about my experience as a mom of a 10 years old boy, Andrea, who has cerebral palsy. And actually, I will tell you that during our story, we try to find as many information as possible. We just wanted to look for something different or something other than what the national healthcare system offered. So during the first years of Andrea's life, we tried many different things, and we wanted to look at any possible options, which is what you are doing. Then the method we found is the so-called conductive education, and I will describe it to you, and in particular the benefits we have. Now, Andrea has cerebral palsy. The diagnosis was made when he was 10 months old. Well, it was a premature delivery, but actually there was a problem in the womb, so he had a serious cerebral lesion. And first, we were told to actually contact the national healthcare system, and we did that, but I think that, well, back at the time, I thought there were other options. Of course, well, I knew that it couldn't reach, let's say, 100, but I thought it could reach a sort of 40, But in our situation, it was a kind of a 20 level. So I thought we didn't do enough to actually fully develop his potential. So we went to the Policlinico in Milan, and actually the hospital actually welcomes parents, and they do offer service for parents actually rather than for children. So they really awake you. So there are extremely competent people, and they told me for the first time that you should try the conductive education with Andrea. But actually in Italia, there is only one center in Turin. I live in Ancona, so Turin was quite far away, or abroad, because in other countries there are lots of centers for conductive education. So I went north, Italy, so I went to Turin. Andrea had been crying for 3 weeks, but that was actually good because it was asked to do something more than he knew. So actually, after 3 weeks, minor achievements were obtained and remained over the following weeks. Of course, the improvement curve at first is much more steep than, well, of course, it won't reach maximum performances or the performances of a normally developing person, but the impact was extremely positive. I mean, I had twins, so with Andrea was 3 years old when I started, but then I said, okay, we try this, it's positive, and I continued because it was, I mean, at the beginning we went abroad, we tried oxygen therapy, we went to a hospital in Pavia where he was hospitalized many times. We also tried the Therasuit. So we actually had it in the United States because back at that time there was no opportunity in Italy. We live in Ancona, so there is also there are a lot of experts when it comes to sensory development. So after all this, sometimes also kind of opposite views and contrasting views among doctors and physicians. I don't know if you agree with me, but sometimes physicians or physical therapists provide contrasting information or contrasting suggestions. Sometimes they say he has to lay on the floor, or he can't, or he has to swim, he doesn't have to swim. So sometimes you really can't understand what decide, because I mean it's really difficult because you try to understand, but all doctors and all physicians and experts have their own suggestions, and might be part of what they say is true, but then in the end you have to decide, you know, the pathway to follow, and it is up to us as parents to do that. So at a given time, well, I understood that I had to stop because I couldn't go ahead with such a life because, as I said, I had twins, so I had another child. So I came back to the experience in Turin. I contacted the physical therapist. I wanted the physical therapist to come and see me for 1 month. So this is just my experience. It is not PKS. My son has cerebral palsy, so I'm not saying that this is a solution for all children. However, during 1 month, I saw so many things. First of all, she had been working on the independence of the child, and this is very important when it comes to conductive education, because I mean, at least for our experience, independence is not considered, and independence means eating, hygiene, also dressing or washing. Andrea has no swallowing problems or chewing problems, but he just wanted creamy or food. So I had actually to mix everything. So also fish or any kind of food had a creamy texture. So I had to do that. But actually, the physical therapist, what she did was actually, do sort of a winning. He cried, he shouted, but there was no medical contraindication. Okay, of course, there is a medical background, so all the medical records are analyzed. Also, when it comes to motor development, of course, they look at all X-rays, the general conditions, the parameters when it comes to bones, but Andrea had no problems in terms of chewing and swallowing, so the therapist said that he had to eat everything, and so she worked on that. Also, the potty training. Well, this is actually a method from Hungary, and all the therapists actually are trained in Budapest, in Hungary, so the work is done in English. And this is not a problem for children in particular. So they do the potty training. Okay, so they train the child to use the potty, and with Andrea, it worked. Okay, it didn't use the potty. It doesn't speak. We don't even know if he feels the need to go to evacuate. But with the potty training, well, actually, they associated the physical place or the P word with the possibility of doing that. Well, it took 2 weeks, and it was taken to the bathroom every 20 minutes. Of course, it was kind of, difficult, but, now Andrea doesn't speak. It doesn't say that he has to go to the toilet, but he knows where to pee. We use the diaper just because sometimes he has some behavioral problems that, of course, interfere with this. But, however, thanks to the potty training, now when we say, go and pee, he does that. And of course, this is a great result for hygiene, for the skin, and so it is very important, a very important achievement. So independence, so making the child, independent. And also the another aspect we have been working on with conductive education is that, the typical session is that, it is a couple of hours, and, when it comes to Andrea, he was hypertonic, so when I actually, this is something I realized during standard therapy. Actually, he had to stand and they push him, and that was it. Okay, so that was kind of the standard physical therapy sessions, whereas with the conductive education, you have to prepare the body for the activity. Okay, so I want you to be in the best possible conditions, and we do that passively. So, we are talking about hypertone in this case. Okay, so maybe in the PKS is difficult, but for example, in this case, in his case, for example, I had equine foot, so we had to prepare him, okay, so 30, 40 minutes of preparation, of stretching. I do not have any pictures because I don't want to, I don't have like scientific evidence, okay, so he's stretched. There are special tables. So there is a first of manipulation for the knees because he it's like the child we saw wearing the Therasuit. So the legs like this, or the arm, which are folded, the arms folded. But with the Therasuit, it worked. So the posture was correct, but we couldn't continue doing that in Italy. So after the manipulation, well, of course, it won't reach the elasticity or plasticity of a normally developed child, but however, then the activity has to do like a crawling or standing. First of all, he is free in the movement, and this is something you can experience right from the first time. It's like, you know, for us, training for a special gymnastic movement, you know, if we practice and practice, then we can do that. Okay, of course, well, when you have pathology, well, of course, this won't disappear, but we can train, and he can train his muscles. So the stretching activity turned out to be paramount for the following activities. So this project was actually brought at the public school, and so the teachers working with him were involved in this activity, because another feature of conductive education is that parents are involved, unlike in the other, let's say, therapies. You know, I had a 6-month baby, and I was not involved in also changing a diaper, for example, because, you know, the legs were like malpositioned, so I couldn't do that. But, you know, in our center that we have now, we want moms or grandmothers or nannies to come and participate and be involved, because, I mean, all the minor things that help managing daily life and health should be, let's say, conveyed to all of the people taking care of the child. So this is really a synergy that we create with all the people taking care of the children. So the involvement of all the people taking care of the children, this is an important element. I don't know how much time I have, but I just wanted to share with you my personal experience. So from that time on, I wanted really to share with experience with other people. So we founded our association, and we organize individual sessions. We have 7, 8 children, and we also have intensive sessions lasting 2 or 3 weeks. And I think that, you know, it was, at first it was frustrating because I felt I wasn't able to do enough, whereas now I tried and pushed as much as possible, and I think that now I have reached the maximum that my child can reach. Thank you.
Funziona? Allora, per restare in tema, vorrei che Marinella ci raccontasse la sua.
I'm now asking Marinella to tell us about her experience. We do have one case here on PKS. I really would like to thank Giulia Fesce. Giulia, thank you so much, because, I mean, you helped me, you know, familiarize with this, you know, activity. I mean, I found this on the internet, then we started working together, and then we tried with my daughter Sarah 5 years ago. So first approach was delivered in Turin, where we, we liked the environment there, so we got some help. She was not able to, you know, stand, and then she was put on a chair, and then they tried and let her walk. It has taken 1 hour, so they were able to let her stand or crawl, something unprecedented, even if she received, you know, physical therapy twice a week. In some cases, they said, please wait outside, and they let me in because I kept insisting so much. I have 4 children. Sarah is my 4th child. The other 3 children were my 3 children were very young. I come from Bergamo, so much closer to Turin than Giulia, but it was difficult for me to go twice or 3 times a week in Turin. I didn't know what to do with with my other children. So we decided to have an educator at home, sort of resident. So she spent 1 month at home. Sarah maybe was not really ready for such an intensive, work. She cried for the whole day, but they taught her, balance and many important things. So this is something that, she couldn't get. Balance, for example, so they understood the problem and they worked the right way on balance. I think that was too much for Sarah at that time. The situation may be different today. We carried out a heart, examination, hypertrophy of the heart, maybe over effort, too much effort. But we stopped, and then we looked for another educator, but it was impossible to balance, mix and match all the needs we had. It was a positive therapy, that goes without saying. So if it was possible to repeat it, without, going to Turin, it would be positive, and this is something I recommend. Thank you. I hope it will be possible to, meet Giulia, maybe, organizing some workshops or training together. Thank you so much, Giulia. Okay, let's continue. So as we said this morning, I'm now inviting Emanuela Salzano. So she's just back from the U.S., so Children's Hospital from Philadelphia, and she worked there for more than 1 year. So she had a grant funded by our association, thanks to the willingness and the kindness of some families. So we ask Emanuela Salzano to make the point. I think this is the best center in the world in terms of testing, experiments, and clinical lab research. Good afternoon, everyone. Now, before delivering my speech, I would like to thank Samantha and Professor Cocchi. Thank you very much for allowing me to be here today and share with you, hopefully, a concrete contribution to this beautiful event, which is expressing, if you will, the participation, partnership between families and clinicians. This is right at the basis of a fundamental information exchange in order to help children and to foster research. I am a pediatrician. I got trained in Italy in 2016. Last year, I had this unique opportunity thanks to the enthusiasm of the association and the trust and confidence that you have in research and development. So, research on Pallister-Killian syndrome carried out at the Children's Hospital in Philadelphia under Professor Kranz and Dr. Izumi, one of his, let's say, partners. They are not here today, but I'm here on behalf of them. Now, let me tell you about this long pathway. It all started back in 1977 because for the first time in that year, Dr. Pallister described the 2 adult patients with a face phenotype, some specific face traits having to do with epilepsy and muscle tonus alterations due to the presence of what we thought was an extra chromosome. A little extra chunk of chromosome. Bigger, longer than the ordinary chromosome. It was then identified as containing the genetic material that we have in the short arm of chromosome 12. 4 years later, back in 1981, Dr. Killian describes other patients with the same phenotype, same features, and in 1986, they created the Pallister-Killian syndrome term. But actually, we had to wait until 2012, where the trial that was repeatedly mentioned this morning to get the first attempt of, let's say, framing or listing all of the clinical features of PKS patients, published by Professor Carranza. 2 years later, so last year, the number of, PKS patients exceeds 100. At the same time, the same research team reveals the results of a specific project. There was an attempt to better understand the molecular mechanisms underlying the PKS. So list is proposed in terms of candidate genes. Those genes potentially correlated to the clinical features and traits we found in our children contained within that region, the critical region for PKS. Now, in 2016, so last year, I had the opportunity to, strengthen this pathway. More than 200 cases in the world were described. We have reached the 350 today. Now, all of this was made possible thanks to research. I mean, research is the key protagonist of a daily fight fought by medical doctors in order to, give concrete, tangible answers in order to meet the needs of PKS children and their families. We also have to get the same definition when it comes to research. This is difficult because, of course, it is a multifaceted system. We have, for example, basic research, which is the kind of research which is based on lab work, tests, and, it's based on speculation, so we try and identify molecular mechanisms. But these are the right molecular mechanisms that have to be understood. If we understand them, we can really identify new therapeutic standards and aims. We also have the translational research, which is the real bridge between a lab and a patient. Basically, they verify the applicability, the usability of lab-made, let's say, discoveries on the human system. We test, murine models. We work on rats before translating all of this research on patients. Now, the patients are the finish line, if you will, so the final target. At the same time, they are also the starting point, because when you observe patients, if you analyze the information, thanks to this, our awareness level of PKS increases seamlessly. This means we are able to enact supportive systems, customized systems, aiming at reaching early diagnosis or prevention of complications. The main final aim is improving the quality of life and life expectancy of our young patients. Thanks to observational trials, around 2000, we managed to have some prevalence data. This means that there's, prevalence is 1 every 25,000 births. Another study was carried out in the UK between 2005 and 2009. They had 5 patients per 1 million born alive. So the perception is that there's an underdiagnosed number of children because of variable clinical expression, because, all of PKS children have some clinical elements in common, but it is also true that every single person is different and unique. Probably, it's also difficult to identify the genetic, the underlying genetic alteration. Most children, actually, all of them for the time being, are sporadic. So there's presence of the genetic alteration, which apparently is not transmitted by parents to children. This is due to 2 extra couples of the short arm of chromosome 12, the isochromosome 12p. So the origin of isochromosome 12p, the origins are not clear. They still have to be investigated. Anyway, most trials that you can find in the literature suggest as a predisposing factor to the onset of isochromosome 12p a non-disjunction event during the second maternal meiosis. You know that meiosis is a specific process concerning the germinal cells. I mean, spermatozoa and spermatocytes and the maternal cell, allowing for the reduction of the euploid genes, so diploid genes. So 46 different chromosomes moving to haploid genes, which is 50%, or I mean half of this, 23 chromosomes. So you have the first meiotic division. Basically, we have two couples per chromosome, one from the mother, the other one from the father. So during the first, let's say, split or meiotic split, so we have homologous chromosomes migrating to two different poles of the cell to be inherited by the cell based on the longitudinal axis. So in the second meiotic division, every single homologous chromosome has two different parts. We will have two different, let's say, identical cells. We will have four different cells with an haploid set of genes. The genetic set is then re-established during insemination. I mean, the paternal germinal cell containing one copy of chromosome 12 will merge with the maternal cell that should be containing another chromosome 12. So we re-establish the presence of two couples. What happens in most cases, well, this is what we think happens, is that there's a non-disjunction event. There's no separation during the second meiotic division. So during insemination, the oocytes will, let's say, encounter a male cell with chromosome 12. We will create a zygote which has three couples of chromosome 12. So this is predisposing to another event that I have just mentioned. It happens basically within the product of conception. It's a sort of a rescue system. There's basically the rupture of one of the three couples on a random basis. So there's a loss of the inferior part of the long arm, so the short arm stays. The short arm that stays is duplicated. So we have two copies of the short arm of chromosome 12 plus other two copies on the other chromosome. This is tetrasomy, so four copies of the short arm of chromosome 12. Probably you know, but the short arm is represented by P, like petit in French, while Q means, so Q is just following P in the alphabet, so short and long, P and Q. So to further complicate this scenario, isochromosome 12p cannot be found in all cells. You may have a tissue-specific mosaicisms, so this means that in the same person you find at least the two different cell populations. One cell is karyotypically normal, so we have 46 different chromosomes and a population that present an extra chunk, which is two extra copies of chromosome 12. So what usually happens in PKS children is that in the first 28 to 30 days of life, the number of cells in the blood carrying isochromosome drop down dramatically, and then they totally disappear. This means that we understand why, after 1 month of life, we are no longer able to see the presence of isochromosome in blood. So we need another biological sample. I mean, fibroblasts. This is what we do thanks to a skin biopsy, because in terms of fibroblasts, the isochromosomes, I mean, shows the mosaic or mosaicism, so we can see it there. I was mentioning paper published in 2014 from Professor Kranz. It concerns the expression profile of the genes on fibroblasts of PKS patients. You know, the fibroblasts are a very precious asset, if you will, to conduct in-lab tests. So this has shown that actually we have more than 300 different genes that show a different expression profile versus the one you can find in normal, ordinary cell populations. This means that some genes work much more. They overwork, that you can see here in red. Other genes are weaker in green. If you compare the behavior of these cells coming from the same clone of PKS patient whose karyotype is ordinary, while you measured against another chromosome, you can see that cells behave almost in the same way. So based on these two pieces of information or statements, we have a hypothesis that we haven't been able to demonstrate scientifically, but the presence of isochromosome 12p dates back to very early stages of embryo development. Basically, every single cell may show isochromosome 12p. This presence is able to generate a sort of a global, sort of catastrophe, if you will, in every other cell. These cells will, lose isochromosome 12p, just like in blood. We have identified some genes on chromosome 12p's short arm. When they are overexpressed, which is what happens on our patients, well, actually, they may interfere with the function of all of the other genes. Some of them, we know them very well because they are functionally altered, and they may generate the onset of some specific clinical cases, some congenital diseases, cardiopathies, and then there's also a specific skeleton underdevelopment that you can find in PSK. Our database has clinical information on 128 patients referred to the center. Based on this information, as you know, we can see that there's a very special face phenotype. I mean, some many small face traits in the faces of these children, and altogether they are typical of Pallister-Killian. Large foreheads, very, let's say, the hairline is moved back, the mouth shape is also special, thin upper lip, thicker lower lip, malocclusion, and some key marks on the ear. Anyway, all of these elements come with skin abnormalities, usually reduced skin pigmentation, together with other pathologies on different parts of the body. Other congenital diseases were found in our cases, in 11% of cases. Congenital cardiopathy, 40% of patients, but in many cases, these cardiopathies are not dysfunctional from the cardiovascular perspective. Gastrointestinal alterations can be found in 40% of patients on average. In 12% of cases, this is a malrotation. As we said before, all of this should be identified soon after birth in order to have specific care system in order to remove perinatal complications. In many cases, you can see the anteriorized anus, as we said this morning. Neurological involvement is present in more than 70% of patients. Intellectual disability, behavioral problems. In many cases, they come with the alteration of the muscle tonus. It is a hypotonia, so a reduction of muscle tonus, followed by hypertonia. Gastrointestinal functional problems account for 40% of the total, and epileptic seizures can be seen in also 40% of patients. In terms of visual impairment, 74% of patients, together with a reduction, hearing impairment, 60%. Genital urinary tract abnormalities, 32% of patients. And as we said before, it's almost always males. They have an enlargement of the pelvis or the lack of the presence of the testes and some urethral problems. In girls, we don't have data. The paper that was published in 2012 doesn't show any data on girls because we don't have them. Paradoxically, you can find some data if you analyze the literature on fetuses. 4 cases are present in the literature of 4 females with some Müller-like problems, bicorneus, for example, uterus with atresia of the vagina. Now, in terms of development profile, some points have been raised already today. So there's an increase of birth weight, usually followed by a reduction of growth speed from the first year of life. Now, the progression through the different steps of the neuromotor phases is not always acquired. When it is delayed versus the physiological development. So on average, the rotation takes place at 11 months, setting position 21 months, first vocalization 36 months. Independent gait, when reached, comes at around 40 months. Behavioral problems have not been investigated enough, so this trial was carried out on a very small number of patients, 16 patients, 75% of patients with stereotypical movements of the limbs and head with dizziness or lethargic attitude. Less frequently have we described self-aggression, self-injury, or hyperactivity. So based on all of these clinical elements and based on molecular mechanisms, we have designed some research lines of my activity in the past 18 months. On the one side, on the clinical point, they are aimed at identifying prenatal profile of PKS in order to orient, to work on diagnostics as much as possible. On the other side, they have been done to correct PKS in patients with a different ethnic background. In terms of basic research, the attention was drawn on the attempt to identify new potential therapeutical approaches in vitro right now, so on cells, basically via the inhibition of the proliferation of fibroblasts containing isochromosome 12p. Now, this research comes from so-called chromosomal therapies, and they are aimed at eliminating or silencing one chromosome or maintaining euploid chromosomes, the right balance inside the cells. 2 trials were published on cells back in 2011. They were able to show the yeasts, but also fibroblasts of rats with one extra chromosome in their cells do share a change of the cell behavior, no matter what the origin of the chromosome is. This is due to a seamless attempt. They tried to remove the increased protein intake due to extra chromosome material. On the one side, this correlates with basal stress inside the cells. On the other side, we see a reduction of cell growth speed. If you check growth curves of an ordinary euploid line together with the uneuploid, with one extra chromosome, you can see that the growth speed drops down. Now, this metabolic condition makes them very more sensitive to the activity of some drugs that directly interfere with these metabolic pathways. So, based on this evidence, another trial was carried out, and then MIT from Boston published another paper. They have checked the responses of different chromosomes from rats after being exposed to a long list of drugs able to interfere directly or indirectly with basal metabolic stress. 2 drugs turned out to be very interesting. One is ICAR, the other one is 17AG. It's a synthetic byproduct. Results, outcomes highlight the fibroblasts, trisomic fibroblasts that you can see here with, white columns. This is chromosome 13. They show much higher sensitivity to ICAR versus the normal cell lines that you can see in the black columns. This is inhibiting selectively the proliferation of fibroblasts with one extra chromosome. So we have repeated the same tests with the second drug, 17AG. So apparently it is a little less effective than ICAR, but if you use a combined mix of these two drugs, we can get a remarkably bigger, stronger effect in terms of reduction of cell proliferation of the lines, transporting actually the chromosome. This was much better than the previous drug. The combined or non-combined use of these drugs had already been studied, so this is able to inhibit the proliferation of trisomic cancer cells of different types of chromosomes. Thanks to all of these studies, it was possible for us to really improve our knowledge in interpreting the molecular mechanism of 17AG. Maybe a little bit less for ICAR, because in terms of ICAR, it seems to be the most effective drug. We don't know exactly what the mechanism is, but this is sort of interfering with the so-called cell metabolic stress central units that will lead to cell death. The target of the study was to measure the effectiveness of ICAR in inhibiting the proliferation of fibroblasts on PKS patients. So we have morselized clones of fibroblasts exposed to growing dosages of ICAR up to 21 days. And effects have been tested in terms of morphological changes of the cells, or even in terms of global total cell survival rate after the exposure to the drug, but also in terms of quantification of the number of cells still alive after the exposure to the drug, still carrying isochromosome 12p. In the very first phases of these experiments, some amortized cell lines have been used. So these are basically modified lines versus the primary lines, which is what we get from the biopsy of patients. These are much stable lines, a little bit easier to handle, if you will. So the result of the PKS line was compared with the WT, so the non-immortalized PKS. Look at the baseline. Just check the two lines. So once again, the normal one is the WT, the other one is PKS. You can see that the PKS fibroblast line grows slowlier. As for morphological changes of the fibroblasts, PKS immortalize the fibroblasts. This is something you can see 2 days after starting therapy. This is what you see on the top of the slide. This is on our test tubes. So this is the changes of fibroblasts after 2 days of treatment. On the bottom, you see their changes after 7 days at growing doses, 0.5115. The picture on the left is a normal growth pattern of fibroblasts. So you can see that there's a change in terms of morphology. These cells become longer. There's a bigger gap between cells, so there's a reduction of the number of cells. And then if you have 7-day treatment, top dosage, well, this means total disappearance of cells, which is, 1.5 treatment. We have 3 questions. Is ICAR effective on PKS immortalized fibroblasts? Do we have a concentration which is effective on the mosaic fibroblasts, but being relatively safe on control cell lines? Because, of course, we don't want to kill every cell. It has to be a selective action. Then, is there any time and dosage dependent effect? So 2 different questions. Time dependent and dosage dependent effects. If you answer these questions, you understand how you can manage the drug. You can see here the outcomes of our experiment. You have 2 arms. Arm number 1 first lines, so line A and line B. The only difference between the two types is the number we had, the number of cells we had at the beginning. First line used 50% of cells versus B. This is to measure if the effect depended on the number of cells. So we were able to identify a sort of an average dosage of ICAR. So this is 0.5 millimole. This can, inhibit the chromosome that you can see here in gray. Basically, there's no effect on the normally developing line, which is shown here in black. This is what happened in both experiments, but the consequence is much bigger on the first line. Just compare the two gray columns, top and bottom, where we used a smaller number of cells. In terms of genetic set, so just checking, the chromosomic set of the survived cells. 2 days after treatment, the percentage of mosaicism was much lower, close to 2. 2 means ordinary genetic set, the two couples of chromosome 12. And it stayed flat, very close to normal, also in the 4 days after discontinuing the treatment. It was also possible to see that there's an effect depending on the dosage of the drug. We have increased the quantity of drug, and you have a proportional reduction of the number of surviving cells. What we are working on these days concerns two key points. We are testing the second substance, so 17 Ag on immortalized lines. PKS line seems to be more sensitive than the control group line, but in terms of reduction of mosaicism, the effect is smaller than ICAR. On the other side, we carried out the same experiment on primary cell lines, those cells that we derive from skin biopsy, because this is an in vitro model, but it's much more similar to the real actual cells of our patients. So apparently there's reproducibility. Basically the same thing happens. Let me draw my conclusions. We can say that PKS patients are more sensitive to all of these compounds. We have identified an average intermediate concentration of ICAR, which is now able to cause death or lethality in immortalized cells. It goes without saying that these results are very interesting because, they, open new windows of opportunities on possible new therapeutical approaches. At the same time, we cannot forget that we still have some points we need to cast light on. Last but not least, the ICAR working or operating system. There's another point which may be a limit in terms of, applicability in clinical practice. I'm talking about the mosaicism of this syndrome. This means we cannot have many in vitro experiments, and it's difficult to translate all of this in clinical practice. So back to clinics, plenty of efforts were deployed in order to identify the prenatal profile, because it's quite difficult to have an intranatal diagnosis when it comes to PKS. Clinical expression is variable, but you also find it difficult to see isochromosome 12p prenatally. And 80 cases were reported from 1985, but in many, many cases, these are sort of isolated cases. So maybe we lost a sort of a general, vision, the general overview on the problem. In terms of clinical problems, we have congenital heart defects, diaphragmatic hernia. This is underestimated in literature. Once again, congenital heart defects, and then you have the reduction of the femur and the humerus, ventricular issues, and then the increase of amniotic liquid prenatally. So we decided, to sort of filter all of this data. We carried out a retrospective analysis based on the CHOP database. We also sent out a questionnaire, thanks to the cooperation of associations. That Samantha has, made sure you could participate into, this questionnaire management. Some days ago, we have added 2 cases from the Perinatal Medicine Center in Delhi, India. So we have compared this with an extensive analysis. I mean, 86 patients you have data on in literature. In terms of outcome of our examinations, there's an increase of amniotic liquid for many cases, plus the reduction of the femur length in the literature, but also in all of our cases. Back to our cases, we have 20% of patients with macrosomia, so the fetus is bigger than normal. Congenital diaphragmatic hernia accounts for 27% of all cases in the literature, but in our group, we only had 5%, together with heart abnormalities. In our cases, I mean, we have less cases than the average number of cases in the literature. This means there's an enrollment bias. I mean, there's a mistake, if you will, in terms of enrollment, because our cases are based on pediatric patients. This means that they, well, survived extrauterine life, while many data in literature are based on miscarriage, and this is due to the presence of complex malformations. So in general, you know, they sort of got severe cases. Another key point, larger ventricles. This is included in cerebral abnormalities. 20% of the patients in literature have polydactyly, prenatal polydactyly. In the freshest cases, there's a description of the prenatal phenotype. So the 3D scan is able to identify specific face traits that you can see before birth. So you can see this during intrauterine life. And this can really, well, help us identify our suspicions. So if we put together all of the prenatal data now available in all of our cases, plus those in the literature, we have interpolated growth curves for the biparietal diameter, skull circumference, abdominal circumference, and the length of femur. Our cranial circumference is much higher than normal. I mean, if you compare with normal growth rate, it's more than the 90th percentile for almost the whole duration of gestation. The length of the femur is under the 10th percentile in most cases. In terms of identifying isochromosome 12p, thanks to ordinary screening tests carried out during pregnancy, we don't have any special piece of data. I mean, there are no significant changes of the maternal serological markers that we usually analyze when we carry out screening tests. Let me draw your attention on the increase of the nuchal translucence, 17 cases, and then 14 cases out of 16 that you can find in the literature. These are the more severe clinical phenotype patients. In terms of invasive tests, for example, villocentesis and amniocentesis. Villocentesis sees the, I mean, they are not able to see the extra chromosome. Amniocentesis is better, 95% of identification, successful identification rate. So why am I dwelling on nuchal translucence? Well, because we don't have many such cases, but every single case, plus those in the literature, show congenital diaphragmatic hernia, or much more cardiopathies than what we usually have to avoid complications. There's another element out of these data. The increase of the amniotic liquid comes with acrosomy at birth, I mean a bigger weight. This may bring about complications during delivery. This is a risk factor for preterm deliveries. Congenital diaphragmatic hernia may trigger more risks of complications or death after birth. It should be identified prenatally to identify specific support approaches soon after delivery. You can see here some features of the second quarter, of the pregnancy. You may see the increase of amniotic liquid and then the reduction of the femur length, especially if they come together. On the one side, this means we will exclude the complex malformations we have to be aware of upon delivery. On the other side, if you don't see them, we need to look for minor abnormalities, for example, polydactyly or, the larger ventricles. This is also interesting. If you think there's PKS, even if there's a negative villosynthesis history, we need to have villosynthesis by talking about the diagnostic suspicion. Because, the so-called long cultures, which is what happened in the lab, of the amniocytes, in this case, the isochromosome is no longer there. So if you have this sort of suspicion, you have to talk about this with the specialist, because you may have an array of non-cultured amniocytes, or you just have to focus on the first stages without getting to the late stages. This is my last project. It comes together with NIH. So we want to create this morphology atlas that takes into account the morphological diversities because of different ethnic groups or ethnic backgrounds. Now, this happens because the tools available today in terms of training, but also in terms of, courses or updating courses. Now, all of this information comes from pictures and information coming from European, Caucasian patients. And in some cases, they don't really represent the phenotypical variability. This may lead to delayed diagnosis, which is true especially for PKS, where, as you know, unless you have the clinical suspicions, you may miss the case, but you can also react with blood tests. Just like the Noonan syndrome or the Down syndrome. So we did exactly the same thing. We have here 14 cases, 4 from Asia, 5 from, Southern America, and 5 Afro-Americans. We examined clinical features, but also the profiles, the silhouettes of the face. Figure 2, you can see Indian children. Figure 3, Hispanics. 4, Afro-Americans. Now, if you look at these pictures, what you see is a difference. Phenotypical variability even within the same ethnic group. Anyway, apart from these, visible differences, in my opinion, there are some clinical elements that are sort of diagnostic manias, common traits, which are there no matter what the ethnic group is. So same feature, you can see, alopecia, so a hairline is moving back, the shape of the eyes, and even the shape of the mouth. Many patients present a special morphology of feet and hands, a little, smaller and fattier. In terms of skin pigmentation, now, Afro-Americans have a wider spectrum of skin manifestations. So you can see depigmentation, hyperpigmentation, and usually they have a very dry skin. This means eczema-like lesions. In terms of structural abnormalities, in general, Asian patients show more cerebral abnormalities, so bigger ventricles. We also found an abnormality in the cerebellum of one patient. Hispanics with gastrointestinal malformations. African Americans have abnormalities in the anus rectal tract. All Afro-Americans have a positive gestational anamnesis, increase of amniotic liquid. So this is what we think. Patients at risk of being misrecognized or with delayed diagnosis are the Asian patients. The future, directive or guideline, we're now working with Dr. Munk. We would like to collect as many pictures as possible of patients from different ethnic backgrounds. We would need at least 40 in order to test the face recognition software programs in order to improve diagnostic capabilities, especially in those countries where access to care or genetic tests is difficult. This was, I think this is my last slide. This is what's coming up. This is what's in the pipeline. We are now working to create dedicated specific growth curves for PKS. We're also working on another interesting point, which is the overlapping of a phenotype between PKS and the Bacpidema syndrome. There are common features, so amniotic liquid increase, prenatal growth pattern, abdominal wall, macrosomia at birth, hemihypertrophy. There's a different length between two limbs. So we want to study the critical region that most correlates all of these aspects. So we will make a comparison between the two syndromes. This is also very interesting. We have to work and assess on the PKS natural history, including comorbidities of these patients. We saw that what we don't have is the characterization correlated to the, more advanced age, starting from 12 years of age onwards. So chronic conditions, comorbidity may help us understand something more about life expectancy. We are doing two different things. On the website, we identify the candidate gene. For example, we would like to induce the overexpression of all the genes you've seen before. We also would like to compare the behavior of cells with the overexpression of every gene together with PKS patients in order to find the right match. The second study concerns therapeutic targets. Basically, we want to investigate on the functioning of ICAR. We will be testing ICAR on those cell models very similar to men. PS, they differentiate in different tissues, so we know how the different tissues respond to the administration of this drug. There's another line we are working on. We're now drafting a project, gene therapy. There's a gene who's called ZSCAM4. It is implied in maintaining the right cell genetic set. It was shown to be able to convert trisomic cells of Down syndrome patients in some disomic cells. We would like to overexpress it in our fibroblast of PKS patients to make sure what its effectiveness is. That was my very last slide. Thank you so much for being patient. I hope you found this interesting. Once again, I would like to thank all the people who gave us their contribution in order to make all of this possible. The Italian Association, that was our starting point, Samantha, US Association that has funded, the postdoctor that Dr. Kranz has given me, and Professor Cocchi. Thank you so much to the research lab, the CHOP. Last but not least at all, Marinella and Massimo and all the families and the PKS children. Without them, all of this wouldn't have been possible. There's a nice phrase from President Obama. Our children deserve this effort to have seamless, continuous knowledge. We have to keep on going. Thank you.
we actually have to thank you for what you are doing, for your commitment, and also the fact that you moved to the United States. And I'm pretty sure it is an extraordinary experience, but I know that you're far away from home. And actually, the knowledge you're acquiring, your commitment and passion. So we would like to thank you for what you are doing. Thank you.
Bene, adesso torniamo a una realtà più vicina a noi, vale a dire quello che è la cura e l'assistenza.
Now I would like to give the floor to the next speaker, and the presentation is about care and assistance, and also sort of guidelines for families. So Alessandro Rocca and Giacomo Spetti, they will both present the project. Actually, it is a project of care and assistance guidelines for families. Alessandro Rocca and Giacomo Spetti graduated, and their graduation thesis is on PKS. I'm not aware of any other students who graduated and studying the PKS. Giacomo Spetti graduated a few months ago, and actually they are now specializing in PKS studies. So now the floor to Alessandro. Okay, we will be sharing our presentation, and our target is families, because you represent the reality we met as students. So we'd like to start with a very short introduction. And this introduction is meant to thank all the people who made it possible. So this is just the introduction to our project, which is dedicated to you. To you as families, you have a story that actually, for some families, starts even before the 7th of June 2011. For us, everything started on the 7th of June 2011 when Giacomo was born in Bologna, and the following weeks, Samantha and Paolo received the diagnosis of PKS. So Samantha decided to work on this piece of information in a constructive way, and she founded PKS Italy. Some years later, actually 1 year and a half later, there was a younger and thinner physician who is not Professor Cocchi. I'm actually talking about me. And I actually decided to prepare a thesis on PKS, so I met Samantha and I started my research on PKS. It was not just me. I worked with at least 15 families, and many of them are here today, and they were extremely kind to answer to my questions, and they allowed me to know the state of the art and the situation in Italy. And I also compared data available in Italy, and let me mention once again the paper that we have mentioned since the beginning of this day. Then I graduated, but also in 2013, the first European workshop was held in Loiano. And actually, well, it was the same structure. So one-day conference on PKS, and that was an extraordinary experience to me because physicians could meet parents and families. I think it's not banal to repeat that families attended the conference, and that is extremely important because we have chance to understand the real needs of children. So all the inputs from families, also the following years, actually started in Lugano when the first European workshop was organized. I also would like to remember the dinner for Sara. Actually, Marinella's family organized such event in September 2014, and also on the 3rd of December 2015, when thanks to the funds raised, we actually had the possibility to start to have a research grant. 2015 was also an unfortunate year because Simone passed away. And I think that this incident reminded us that our children are fragile, but that was also another opportunity to continue in a constructive way our research, and actually research continued. And we will pursue this pathway and continue to conduct research. Then in 2016, 2017, I had the honor and pleasure to meet Giacomo, and that was an opportunity, a further opportunity for me to carry out a study on PKS in Italy. And once again, I have to thank all the families. The number of families increased, and I could actually compare data and compare data with case reports and reviews in literature. And so now I give the floor to Giacomo, who will tell you something more about his thesis.
Grazie Alessandro per la parola. Volevo ringraziare anche il professor Cocchi.
I would like to thank Professor Cocchi, Samantha, and all the families and parents who allowed me to actually graduate, and that was thanks to their extremely important contribution.
Ecco, il titolo della mia tesi è stato la sindrome di Pallister-Killian.
The title of my graduation thesis was a syndrome of Pallister-Killian, prenatal profile evaluation and postnatal clinical phenotype. So we analyzed, as our colleague from Philadelphia explained, we analyzed the prenatal ultrasound abnormalities. We started from our patients in the hospital managed by directed by Professor Cocchi. Up to date, we have 5 patients. And however, in order to have other cases, we contacted Dr. Carletti, who made it possible for us to meet all the families. So we prepared a questionnaire to collect information about pregnancy, delivery, neonatal period, dysmorphisms at birth, organ abnormalities at birth, and later on, neurological phenotype and PKS diagnosis. 23 questionnaires were filled out, 14 boys and 9 girls, sex ratio 1.6, age range from 8 months to 20 years of age, and the mean 8 years and 9 months. In terms of prenatal abnormalities, the most common one is the abundant or increased amniotic fluid. Then we have reduced length of the long bones, cerebral abnormalities, and also genitourinary abnormalities and diaphragmatic hernia. We analyzed the abnormalities at birth, and in particular, we identify bumps on the forehead, sparse hair, specific lips, and also the low sides of the ears, and the large nose bridge, Pallister lip, hypertelorism, and in particular that was very common. We also found dysmorphisms such as the sacral dimple and in particular the single hand fissure. We also analyzed congenital abnormalities. In particular, we found atrial septal deficits and ventricular septal deficits, malformations in the digestive system, and as to other malformations, in particular in the anus, as you can see, 38%. The congenital diaphragmatic hernia that was found in basically 11% of the cases. And also we had found other abnormalities when it comes to the genitourinary system. We also assessed the anthropometry at birth, so in particular the weight, length, and head circumference. Our population represented by the blue bars, and you can see that we have a percentile which is over the 50 percentile at birth. Sometimes we reach the 90 percentile. Then we checked the same values during the last check, and actually we found that if you look at the blue columns, the blue bars, you see that actually the percentages drop and the values drop below the 50th percentile. And so percentages are quite similar, and also population distribution is quite similar to what we have seen. Then we analyzed abnormalities at follow-up, and we found hypo and hyperpigmentation in the skin, which is typical of PKS. In 17% of cases, we found ventricular and septal hypertrophy. There are, in particular for males, we have undescended testes in up to 80% of the cases. We also found musculoskeletal abnormalities, although percentages are lower, such as for scoliosis. Now, as to the neurological phenotype, at birth, 90% of the cases have hypertonia. So hypertonia actually affects the neurodevelopment because, well, the main stages when it comes to development are delayed. Actually, for example, sitting independently, usually that happens at 12 months. Or when it comes to walking or speaking, well, many cases, most of the patients do not reach this ability. And also, well, in an extremely high percentage of cases, so 40% of the cases, we actually found epilepsy. In addition to these abnormalities, we found malformations in the central nervous system, in particular when it comes to the dilation of the ventricles, but also the some impairment when it comes to the visual and hearing systems. So in particular, 60% of the cases, we found vision impairment, nystagmus, strabismus, and we found one case of coloboma. And in 70% of the cases, we found hearing impairment, bilateral and from moderate to severe, and neurosensory type. So these are the main data we found during our analysis, and that was basically the data I used for my graduation thesis. And now I give the floor to Alessandro, who will actually move to the most important part of our presentation, which is sort of a guidelines for families. And now the floor to Alessandro. First of all, let me point out that it is not easy to recap the guidelines or indications or recommendations because, well, on one side, we risk of being too general or generalist, and this means that we might forget some problems or issues. However, based on the information available so far, we can, first of all, consider two main groups when it comes to the suitable and proper care of children and the follow-up of children. So there are different needs if you consider a baby with PKS or a child, so an older child. So for a baby, for a newborn baby, we can say that these professionals indicated in this slide might be involved, so surgeon, neonatologist, cardiologist, and for an early care of the child to ensure the neurocognitive development and neurosensory development, also neurologist or neuropsychiatric, ophthalmologist and audiologist. As to the neonatologist, we can say that a PKS child, as Emanuela said before me, actually can be born after pregnancy, which had some problems, such as the increased amniotic liquid, and this means that there might be cases of premature children, and so this means that further fragility is involved, and the neonatologist has to consider this. Generally speaking, and these data were collected by Giacomo concerning the cases we analyzed. So hypotonia must be taken into account and managed correctly because this may affect feeding difficulties that we found in actually fewer cases than expected, and also hypertonia can cause respiratory distress, which can be managed or handled in the by the neonatologist. Now, the surgeon is involved when abnormalities are found in the oral cavity, for example, the cleft palate. Well, you can see here data concerning the main cohort groups, so the American, British, and Italian groups. Of course, I won't give you details, but I would like to point and draw your attention to the most important features. So the surgeon is involved in case of cleft palate or in case of hernias, and among our cases, and we found that actually the percentage was lower than what we found in literature. So diaphragmatic hernia must be detected as soon as possible, and surgery is required. Umbilical and inguinal hernia, well, in this case, it depends on the severity of the condition. However, a follow-up is needed and surgery is requested only in some cases. A PKS child can also have anus and rectal malformations, and only in some cases they require surgery. Then undescended testes, well, this macro category includes all situations in which testes are not identified in the scrotum, but in some cases, actually, they actually descend, whereas there are also cases in which they are undescended, and so surgery is required in these cases. Now, as to the intervention of the cardiologist, a newborn baby can have congenital defects. These can be also diagnosed at prenatal stage, or however found right after delivery, and so the cardiologist has to actually correct them. So in particular, atrial and ventricular septal defects, and also, for example, the patent foramen ovale or the patent Bottalus duct, which has to be closed in order to ensure the survival. Sometimes it doesn't close, and sometimes drugs are used or surgery as an alternative, and also some abnormalities in the heart valves. Then the neuropsychiatric is involved in the neonatal stage, and in particular, he or she has to bear in mind that the child has structural abnormalities, for example, concerning the brain, as we said this morning, and this was confirmed by our study. The neuropsychiatric also has to consider the condition of hypotonia and epilepsy, if present. Actually, during the first years of age, epileptic condition is described. So these are the, let's say, conditions at baseline that the professional has to take into account in order to basically then intervene for the neuromotor development of the child. Then, of course, also the ophthalmologist is involved. So the site is assessed, and also follow-up visits are requested in order to identify visual impairment. There are many cases in our population, and they do actually affect the development of the child, because they actually affect the visual and hearing systems. And these two systems do affect the growth and development of the child and the relational skills with the environment. So to recap, during the neonatal stage, first of all, we need a clinical evaluation. So neurological, neonatological, but also involving surgery and cardiology. So when it comes to the options or the tools, well, the echoencephalography is needed, as well as echocardiography of the abdomen, of the urinary channels and kidneys. So that is basically our baseline, our starting point. Then also the hip ultrasound. We must ensure the ultrasound, and in particular, if all the risk factors may affect the situation, we should understand if there is a risk of congenital dislocation. And also for the ophthalmology, well, starting from an assessment of the fundus oculi, and also the auditory brainstem response. So we have to consider also the secondary assessment, such as the ABR, that do evaluate the response to acoustic stimuli. The assessment, the evaluation of the digestive tract is also important in order to basically rule out malformation in the digestive system. Now, if we move from the newborn baby to a child, you see that there are other professionals involved. Well, first of all, the pediatrician will be the reference for the family, and the pediatrician has to actually make clinical evaluations to identify new problems, if any, and to forward the family to the professionals. In terms of frequency of checks from 0 to 2 years of age, the assessment by the pediatricians should be performed every 3 months, then from 2 to 4 years of age, every 6 months, and after 4 years of age, once a year. Blood chemistry tests and urinary exams are also needed, and that should be done when diagnosis is given to the family. And they should be repeated at least once a year or more frequently, depending on the outcomes of the clinical evaluation. Now, as to the neuropsychiatric, the infantile neuropsychiatric is another professional taking care of the children, and in particular, as the child grows, well, it has to take care of seizures, of epilepsy. I can tell you that based on the studies carried out in the United States, epileptic pattern was identified. So basically a set of features that were found in the United States, and also the same set of features or pattern were found in the United Kingdom. So, for example, the neonatal seizures are not so frequent, and actually the onset is when the child is 2 to 5 years of age, and seizures can change over time. In Italy, we do not have a clear idea of this pattern. So as Professor Cocchi said this morning, and I'm repeating it once again, we will start a systematic study on this, and I hope I will rely on your collaboration. I know that Samantha gave you some documents, because we also would like to look at the records, because we would like to identify common features for epilepsy, and also for the state of the art on neuroimaging and the neurological condition of children. So generally speaking, the neuropsychiatric has to be involved right from the beginning, and he or she has ensured a follow-up basically every 3-6 months, but such a frequency can change depending on the growth of the child and depending on clinical indications. and also the instrumental assessment, for example, all the tests and exams, so they are made based on the clinical indications and on the needs. We do hope that pediatrician and neuropsychiatric collaborate with the other professionals in charge of education and assistance. And actually, we heard about that this morning. And these professionals are as important as pediatricians. And of course, in this case, the interventions must be customized depending on every single child. And we have to make sure that children develop their independence in order to live a daily life in the best possible way within the family and in the society. So ophthalmologists, audiologists, they intervene and they have to monitor the condition of the child, and they also have to assess the neurosensor development and intervene whether needed. Now, concerning the cardiological aspects, well, if there are no congenital diseases or defects, well, the cardiologist, however, has to periodically evaluate the child, and so a visit must be performed, and also echocardiography is needed, because some cases were reported of, in particular, hypertrophic cardiomyopathy and aorta dilation. And so this is why every 1 or 5 years, heart controls and checks must be performed. We came up with this slide, so we invented this slide, because when it comes to lungs, well, there are no indications in literature. However, based on the information you provided us, the respiratory system, but when it comes to the throat, cough, but also pneumonia, for example, I mean, these events are not so rare, so they are actually quite frequent. And so some respiratory problems mainly occur while sleeping. And so we would like to further study also this condition. Also in this case, the pneumologist has to be involved upon diagnosis to have, let's say, the baseline situation, and then it has to intervene based on needs confirmed by clinical indications. Now, for the gastroenterologist and all the other associated professionals, well, if malformations are not present, so anatomic malformations which are identified at neonatal stage, but later on, however, we know that we might have problems of dysphagia and also reflux. So I won't get into details because you have been talking about that this morning. However, we have to involve gastroenterologists and professionals. And as we said this morning, unfortunately, the diagnosis of reflux in the adult is quite easy, whereas for children, well, we need to perform tests and exams in order to detect it. However, recently, there are indications for therapy to be administered in case of suspected reflux, without demonstrating the presence of reflux with invasive instruments. Now, the nephrologist is involved when based on X-rays of the abdomen, for example, if an abnormality is detected, or in case of infections to urinary ways. Well, in this case, the nephrologist is involved to monitor the urinary system and kidneys, because there might be abnormalities that have to be taken into consideration. So the nephrologist will actually perform X-rays or ultrasound and other specific exams depending on the situation, of course. Now, as to dentistry, we had a very precise and detailed presentation this morning about dentistry aspects. So we should start with evaluations from 1 year of age, although even before 1 year of age, even before teeth eruption, a sort of preventive therapy can be adopted. Various exams are available to identify specific conditions and to better understand, for example, malocclusion. When it comes to prophylaxis, well, fluoride, toothpaste, and also tooth cavitations or sealings, well, these are things that can help us, considering also a regular follow-up, which allows us to correct our interventions. Now, when it comes to orthopedic aspects, we know that this professional has to take care of alterations of the limb ends and also shorter limbs, hip dislocation, which could also occur due to hypotonia over time, and also all problems to the backbone, and also in this case, hypotonia affects all this and creates this condition. So also this professional has to make a first evaluation, and then by using X-rays in particular, he or she should actually come up with the right management. Now, to conclude, the follow-up for these children must be a general follow-up, which involves all the professionals I have mentioned, and they should also collaborate also with the professionals in charge of the neurosensor development of the child, and also a specialist follow-up where professionals are contacted when needed, some of them regularly, and using specific tools and instruments. Thank you so much for your attention. Now, we would like to conclude with some information about vaccination, because, well, vaccines are also important for PKS children, and it is actually a hot topic, in particular in Italy, of course. So, vaccines for PKS children, based on some questions that parents may ask. So, first of all, is, let's say, PKS, let's say, compliant with vaccines or vaccinations? Well, PKS has no contraindication for vaccinations. First of all, because BKS does not involve primary deficit of immunity, basically, and also because it does not have metabolic abnormalities. And also, if a PKS child has some problems, should we vaccinate him or not? Well, we know that there are some problems such as epilepsy, hydrocephalus, congenital cardiopathy, also autism, and problems to the respiratory system. Well, also in these cases, there are no contraindication to vaccines. So the question is, are there any contraindication for vaccinations in PKS children? Well, there are two main contraindications. First of all, severe allergic reaction to the vaccine, and second, if there is an allergic reaction to a component or an element of the vaccine, because you know that in the vaccine there are many elements, many substances which are included, and so sometimes such as gelatin or some like flour proteins or milk proteins, so the child might be allergic to that. And also, when the child has a severe ill, and so is severely ill, so in this case, if he has fever, for example, you should postpone vaccination. And another precaution is if the child is allergic to latex, which might be present in the syringe. So now, what are the side effects of the vaccine? Well, I don't know if you managed to read the slide. However, considering the most important vaccines, well, the contraindications, or the side effects in this case are fever and adverse events on the injection side. When it comes to measles, for example, sometimes there is a complication which was found in 30,000 cases, or some other complications, but in one case out of 1 million. Now, another possible question is, what are the mandatory or the recommended vaccines? Well, you have the list. Of course, this refers to Italy, because in Italy we have some vaccines that are mandatory. However, I know that there is a family from the UK, and well, in the UK there is no mandatory vaccine. However, 100% of the population received vaccines. You know that in Italy, a new legislative decree was issued, and well, in particular, mandatory vaccines have changed because, well, in the past we only have polio, tetanus, and hepatitis. So basically, we had only 4 mandatory vaccines, whereas today we have many more vaccines. So in particular, anti-Haemophilus and in particular vaccine for 3 pathologies, including measles. And of course, these vaccines are not administered, let's say, separately. Actually, we have 6 vaccines together and 4 vaccines together. Among the recommended ones, we do have vaccines in particular for the meningitis, and in particular strain B and C. this is our vaccine plan for 2015-2019. And in particular, for the first 6 vaccines, you have to do that at 3 months of age, 5 months of age, 11 months of age, and 6 years of age. Whereas for the other 4 vaccines, basically this is done at the 13th and 15th month of age, and then when the child is 6 years of age. So these are the mandatory vaccine. Then another question about the vaccine for the flu. Well, a child with PKS actually should have this, should actually do that, because it has some risk factors such as chronic diseases, in particular concerning the respiratory system. And the child can also increase the secretion, in particular in this case, or there are other children that might have congenital cardiomyopathy. So this is why they should do this vaccine. And this is it for my part. Thank you so much for your attention. Okay, we are at the end of our day. However, if you have questions for our speakers, also the speakers of this morning, I think they are still here with us. So if you have questions, do not hesitate to ask. Any questions for Professor Magister and her colleagues? I wanted to ask a question about constipation, because my son is 20 years of age, and actually he evacuates only every 4 or 5 days. So I just wanted to know something about constipation, because actually they suggested some kind of drug, but I mean, it was impossible to manage at 20 years of age. So do you have any other suggestions? Well, not really laxatives, but something else for constipation. So he evacuates every 4 to 5 days, and he does that spontaneously, right? And evacuations do not create problems. Okay, so no abdomen pain, or what about feces? Are they hard or? No, not really. Because, well, the definition of constipation, well, of course, is based on the frequency of evacuations, but I mean, every condition and every child is different, because, well, even if the frequency of evacuation is low, if you don't have clinical effects or consequences, well, you shouldn't search for regular evacuations. With the drug you mentioned, well, you have to modulate it depending on the child. We have a standard dosage, but, well, we always say to parents to modulate it based on the response. You could also try and decrease the dosage of the drug, just with the purpose of making feces softer. Well, I don't think there are other drugs where maybe there are some natural possibilities, but, well, with Macrogol, I would try and reduce the dosage. And, well, of course, I know it would be better to evacuate more frequently and not once every 5 years, but if there are no major effects, I wouldn't, worry about that. Another question about the reflux, because we actually made a test because he had some respiratory problems, but well, Federico was like 8, 10 years of age when we did the test. Sometimes I see some yellow stains on the pillow, in particular when he sleeps on the left-hand side because he has severe scoliosis. So instead of using drugs, could we use like pharyngel, or, I mean, it was working with me, so I don't know if it could be useful for him as well. Well, pharyngel is a gastroprotective agent, so it creates a protective film, and basically it creates a protective film, as I said, to actually reduce the action of the acid reflux. However, if there are clinical indications such as the wet pillow or irritation, well, we know there are many reasons for that. We know he has scoliosis, or, well, this could be a problem. But during the day, do you have any other like signs for suspecting of reflux? Well, having a therapy with no signs or indications, well, this can be done if you have a strong suspicion because reflux have important symptoms and creates a distress and discomfort. So in this case, we could do that. But so in these cases, well, the treatment is recommended, but I think that in the other cases, a clinical follow-up is needed rather than starting immediately with the therapy. Any other questions? There is a question here. My daughter is Erica. She's 20 years of age, and I have a question about constipation again, because we don't know if she evacuates regularly, because, well, everything was okay until January, but, well, she had problems, she fell, and then a lot of problems started. She had more frequent seizures, and also as to the menstrual cycle, so the periods were delayed. And really, now she evacuates hard little balls, and so the feces are extremely hard, and she's in pain when evacuating, and we used natural products. We actually followed our doctor's indications, so she eats fibers. Actually, she eats everything, but we try to also have fibers or also whole grain pasta, so we all eat this. But in addition to eating more fibers, we were also suggested to use a natural product to make feces softer. And it looks like that it works, but just for a few days, and then it doesn't work anymore. So every 2 or 3 days, well, Erica actually is able to actually use the toilet, so she's independent when it comes to the toilet. And when I actually realized that she's going to the bathroom, I try to follow her, but actually sometimes we can't see if she evacuated or not. So every 2 or 3 days, I actually use a natural product, and if we do that, actually it works. And I saw that this works just for a couple of days. So we used the enema, and it works, but not for so long. Well, So you were saying that until January, well, the situation was okay, but you know, many factors might affect the evacuation. So I don't know if you change like the drugs or the therapy. Well, 3 months before that, when she had the seizures, actually, she had seizures, but we were trying to actually reduce the dosage of a drug, but she had a syncope, so I don't know if the syncope was the effect of that. However, everything happened when we tried to actually reduce the dosage of a drug. So when it comes to handling or managing constipation, we suggest increasing the intake of fibers, of course, but when it comes to constipation, there is, in these children, you know, there is an alteration of mobility. So if you have fibers, well, you create a sort of a mass effect because the fibers increase the volume of the feces, but the feces remain in the gut, so they do block the intestine and they do create a fecaloma. So this is maybe what happened. So we suggest using more water than fibers in this case. Well, she drinks a lot, so this is good, of course. But I mean, since let's say a number of factors changed the way she evacuates, so I would start with a drug aimed at improving the texture of feces, because, well, if we do not intervene, there might, you know, this might trigger a vicious cycle because, well, she now feels pain when evacuating, and of course this could also cause fissures. So I think that you should intervene. Sometimes colleagues do not recommend drugs for constipation because they think that actually the patients become dependent upon drugs. But actually, I believe that we should try and resolve and eliminate constipation because, well, I mean, in case of constipation, this is painful, so the child will try to avoid it. And also, as we said this morning, she might have feces in the rectum, but then you see some evacuation, so maybe soft and creamy feces, so you see them. But actually, this means that you should use enema for the evacuation, but then, you know, the feces remain. So we should use an oral treatment, an oral therapy to make feces softer. Well, I think that actually, when it comes to anemia, I would say you should postpone this because, in particular, I mean, when it comes to children, well, they are worried. They actually are scared. But, well, she's not a baby, but, well, for very small children, you know, they try to do anything they can in order to avoid anemia. So we should start with an oral treatment or therapy. Thank you so much. If there are no other, there is one more question.
Buonasera. Spero che mi faccio capire in italiano.
I'm not Italian, I come from Romania. I have a 3-year-old child, 3 years of age. He's intolerant to milk protein, so he can't eat dairies because if he eats dairy products, well, really the skin changes in the color and he can't sleep. So if he doesn't eat dairies, well, you know, it's okay. But is there something that we can do to overcome this period, or should we wait for him to grow and maybe the immune system will be more mature? Thank you for this question, because, well, intolerance to milk proteins can actually be associated with the constipation. So actually, if you eliminate milk and dairies, well, it feels better, right? Well, okay. But maybe what many other doctors suggested, and this actually happens in many cases, the problem of allergies to milk proteins, they actually disappear over time. So I don't know if you actually underwent special tests or exams. So just based on clinical indications, okay, so maybe over time you could and try introduce small quantities of milk protein and assess the child response. Because, I mean, usually the problem is more evident up to 2 years of age. Well, at home is okay, of course. If you travel, you know, sometimes we can't find products without milk proteins. But however, at home, I would, you know, try with a small amounts and see what is the reaction. Or also using some drugs for evacuating. Well, okay, so if it doesn't eat milk or dairy, so there is no problem in evacuation. So actually, I would start and introduce small quantities, small amounts. So the first starting from the products derived from milk, whereas milk is the last product because it contains more proteins, of course. We have another question now for Dr. Alboresi. My child did FKT, but 4 years ago we had hip dislocation. So now just a few massage and but this morning, I mean, you said something about hip dislocation, so I would like to know what to do. Now, the problem of hip dislocation, you know, takes a lot of time to be dealt with because we do have congenital hip dislocation. So basically, they are already present since the very early age. And we heard that there are actually the two opposite problems. We have hypertonia, which is associated with acquired hip dislocation because, well, the child has such a high strength that, well, even if there is no dislocation, well, in this case, with hypertonia, there might be further migration or dislocation. So the PKS is an example of syndrome in which we can have both congenital and acquired dislocation and also acquired dislocation based on dysplasia. But having said this, I cannot give you one single answer to your question because I mean, hypotonia and hypertonia are two different problems. When it comes to rehabilitation, well, the muscles in your case were not involved if you're saying that there is hypotonia. So actually it was a sort of a congenital dislocation. And actually, in terms of physiotherapy, well, in this case, physiotherapists should be completely different. When you actually perform maneuvers, in particular stretching or muscle stretching on a weak element are extremely risky, because if you want to stretch the muscle, you might weaken the hip in this case or damage it. So, well, in other conditions, well, the hip monitoring is required, and in particular, pelvis x-rays, well, this is always needed. So the hip is the top problem when it comes to physiotherapy. Also, when sitting, you have problems. And there is also another component, so hypermetry or hypermetry, secondary one, because, I mean, in case of his hip dislocation, the limb gets shorter, and also this affects the type of aid or orthosis that I need. Well, in your case, or I mean, I would propose that sometimes they say no verticality in case of a hip dislocation. Well, of course, the load can actually promote it, so can promote dislocation. So such a problem must be actually considered with care, in particular when it comes to maneuvers by the physical therapists. And I also would like to try to explain that, and this is why the PKS is significant, because every child is different, and we need a customized intervention, because if you have hypertonia with hip dislocation or without hip dislocation, well, the therapy has to be different. Unfortunately, sometimes, just the same therapy is offered to every child. Because sometimes they just offer or propose just one therapy, and they think that it fits all children, but actually this is completely wrong. So, for example, in the past, we used a list of exercises, standard exercises, and basically you had a list of exercises and also sort of a dosage, a frequency in terms of times, in terms of how many times during the week. But if we do not know exactly what we have to consider as a target and what is the tolerance of the child, well, we cannot use a fixed list of exercises for all children. So the approach must be different and customized. And now also considering the tolerance of the child, because when it comes to physical therapy, well, we have to start from the child's tolerance. I heard that, sometimes physical therapists, they do not want parents to be present, but actually, I mean, these children have also sensory difficulties. So actually, they relation with the word goes through the body of the mom, and it takes months to actually for a child to accept the therapist and being held by the therapist. So the first exercises actually start when the child is held by the mom, by the mothers, and then later on different systems such as pillows can be used. So we think that this is paramount. If a child cries throughout a physical therapy session, well, I think you cannot accept this. Well, this is difficult for me to accept this. Thank you. We are kind of late, so I think we can just have 2 more questions, and then we will conclude our day. I have a question for the neuropsychiatric. Short one. Is there an acceptable frequency of seizures? So when you start the therapy, seizures decrease, but they do not disappear. So is there like a threshold or an acceptable frequency for seizures? And also, my son, his name is Pietro. We followed many therapies, but he couldn't sleep. He had sleeping disorders or problems. Then I talked to another father of a child with PKS, Franco, and I would like to actually say hello to him. Maybe he's actually following us. We actually administer melatonin. I don't know if it is a placebo effect or not, but that was so useful. It was like a miracle. So if you are not aware of that, that was a miracle for me. So now Pietro sleeps every single night using melatonin. Thank you. Thank you for your question. Well, the first question, well, I would say there is no parameter telling you that a given number of seizures is acceptable. Sometimes it is acceptable considering the global situation of a child, because we want our child to live in the best way possible. So if we look at the whole situation, sometimes it is acceptable that some seizures are not fully controlled, but they do not create distress or discomfort in the life of the child. So if I had to use like 5 drugs to eliminate the seizures and I would have so many side effects, well, I would rather use just 1 drug and accept short seizures that are not so, let's say, distressing for the child. So once again, you have to consider the overall situation, and your target is really the general well-being of the child. Now, you mentioned melatonin. Well, okay, melatonin is very much used when it comes to sleeping disorders in children with intellectual disabilities or genetic diseases. So I'm sure that many other families used melatonin, and maybe, it was not doctors, but it was maybe other parents, suggesting or recommending the use of melatonin. And I think that, well, we should, have a sort of a systematic assessment of all children. So we should be able to look at all these problems for all the children, for example, epileptic seizures or sleeping disorders, and also, having a sort of a systematic review of the solutions which are most frequently adopted and, well, the solutions that work in your daily experience. I hope I answered your question. Thank you so much. One more question, the very last question for the day, if any, of course. The last question and answer. Well, this is a question for the ophthalmologist. He's not here, though. I'm a pediatrician of Greta. She's with us today. I would like to thank all the speakers because all the presentations were extremely useful to me, and I hope this will help me in helping Greta, my patient. I would like to actually know in terms of ophthalmology, well, what kind of intervention should be foreseen? Because we said that the damage concerns the white matter. So we will actually ask this question to our ophthalmologist, and we will share the answer with all of you. Now, I think it's time for a group picture. I would like to take a picture with all our speakers, so all the families and all the speakers together, and then we can conclude our day. I would like to thank you all for being here. Thank you to all doctors, thank you to all of you, and we will see you tonight at 9 p.m. So now it's time for the picture, and then see you later at 9 p.m. Thank you.